Okay, I think you're good to go.
Great, thanks. So welcome everybody to this Center for Practice Excellence Speaker Series discussion that we're going to have today. Really pleased that everyone here is here in the room, and also that we have a number of people who've joined us online. We have sent around a number of notices about this event and upcoming events in our speaker series, and so just really pleased that we're initiating that for 2019. I can't even believe it's 2019 every time I say that. The process for today is that I'm going to talk for about 30 minutes, or maybe less, and then I'm going to turn it over to Susan James, who's here with us from the Ontario College of Pharmacists, to provide some remarks on her perspective and the college's perspective on this work, and then we'll have time for discussion and questions. We have obviously people here in the room, and we also have people online, and so I'll let the people who are online know that if you have questions or comments anytime during the presentation, to please use the question pane that's there and to write down your question, type in your questions, type in your comments, and that we'll address them if we have time. We hope we'll have time at the end of the session, but we encourage you to engage in dialogue that way. That's great. I'll also take this time to let you know that if you aren't on our internal Center for Practice Excellence mailing list, emailing list, sorry, we don't do paper mail anymore, emailing list, and you'd like to be, in other words, if you notice from somebody else or you got it from a more general listserv, please let us know so that we can add you to the internal listserv, and we'll be able to, or internal list, and we'll be able to get you information about upcoming events that way as well. So I'm really pleased today to be able to talk to you about this topic, the future of pharmacy. This is more the near, I'll just warn people, it's the near-term future of pharmacy, not the, I'm not going to be talking about robots who are going to only, you know, there's going to be no humans involved, and a lot of the other future thinking that we can think of if we imagined ourselves 50 or 100 years into the future. So this is really about more about pharmacy in the near-term future, and how to think about what it is we need to do in the profession of pharmacy to really make a difference in people's lives, and what are some of the trends that are occurring, and how do we leverage that thinking and where the profession needs to go so that we can really make a difference for years to come. I will say that this work is done very collectively with the group of people that you see listed on the slide. This is a group of scientists from the Ontario Pharmacy Evidence Network, who are from a number of institutions, including the Leslie Faculty of Pharmacy, the University of Waterloo, the Anthony Best Diabetes Center, Women's College, Chem H. I'm going to forget something, so I'm going to apologize in advance, Briere Research Institute, so that a lot of us got together over a number of months to try to think about this topic, and the output of what we've produced is what we're sharing with you today. I don't have any conflicts of interest to declare. I will say that the funding for this work partially came from the Ontario College of Pharmacists and was also supported by OPEN. So the background to this work was that the Ontario College of Pharmacists approached OPEN a while ago now. I forgot my time. 2 years ago. Okay, thank you, Susan. To produce a discussion paper that really asked us to look at opportunities that could encourage pharmacist use of existing or potentially expanded scopes of pharmacy practice within the healthcare system that could make a difference for people, which is a pretty tall order. You know, what is it that we could do in the near term to make a difference? And the idea behind it was how could by putting forward thoughts in the manner that we were going to do, could that stimulate some discussion about the profession, within the profession, including OCP Council, but really profession-wide, that would help all the moving parts move a little bit closer to where it was that we needed to go. Partially, this request came in response to something called the Model for Evaluation of Scopes of Practice in Ontario, or MASMO, which I'm still not sure I'm pronouncing that correctly, which is a new approach developed by the Ontario Ministry of Health and Long-Term Care in when looking at any new scopes of practice that any health or any profession wanted to put forward to the Ministry of Health. And the other directive that we were given is to think about pharmacy in the coming 5 to 10 years. So this is why it's near future, not far future. So just one quick note about MASMO, because this did start our thinking, although we really did expand our thinking quite broadly from this as we moved along in our work. But I thought I'd share this with you because most people, this was new for me when I learned about it, and I think it's just interesting that the Ministry of Health and Long-Term Care has taken this approach to thinking about how any scope of practice request will be evaluated. And this is from any discipline. So they have put in an approach that is intended to be patient-centered and evidence-based, so that all changes from any discipline are evaluated against whether or not that expanded scope can prioritize patient needs and system needs more highly, rather than perhaps our own professional priorities. So in other words, what is the patient need for this expanded scope? What is the system need for this expanded scope? And then also, what are the patient and system outcomes if this expanded scope was to be put into place? So it was really it's really an opportunity for them to try to use a transparent process to evaluate all these competing new expanded scopes that are coming their way, ideally to lead to higher quality submissions. I think the process is really playing out. Everyone's learning about it. I don't think we know too much about how it's working. I don't know that anyways. You may ask Susan about that later, but the concept was that all the disciplines would sort of be using this process to then make their requests. So with that coming, the thought was, well, what is it that we as a profession of pharmacy would want to put forward, put our professional hats on in response to an expanded scope? Everyone talks about wanting to do this or wanting to do that, wanting to do this in pharmacy. How do we assess what is most needed that's going to make a difference in people's lives? So our author group thought, well, this is an exciting opportunity. We get to sit and think about what does the profession need in the future? So, well, it's a bit daunting. At first I was like, oh my gosh, what did we think we said we were going to do exactly? But really we could look at it as a glass half full. This was actually quite exciting to be able to do. So what we have done is produce a number of things based on this work. We did a white paper that was presented to OCP Council in June, and from that stemmed a journal publication and also a video. And this is just the slides of the white paper and then the publication that we had published in CPJ a few weeks ago. They actually released it online on December 25th. And I went, oh, I don't think anyone's going to be looking at CPJ on December 25th, but okay, it's online now. I'm not sure I can tell anybody about it, but it was out at that time, and so now we're seeing people nicely take notice of it, which is good. I thought I would just spend a couple minutes on the purpose of a white paper, which is different than the purpose of an academic publication. So the concept of a white paper is to provide an authoritative, in-depth report on a specific topic by presenting an existing problem, providing possible policy preference, options, or solutions. So you have a bit of license in a white paper, which is always good. Perhaps when we're doing some of our academically inclined research, we want to be a bit more conservative, make sure that all of our data allows us to make certain recommendations. But with a white paper, we can tell a bit more of a story, which is nice. We do want to seek to provide strategic informed guidance on an issue that's relevant to a variety of stakeholders and can be used to inform implementation and decision-making processes. So this is where putting together our thoughts on the future of the pharmacy and potential opportunities that the profession might have to leverage for the future is really what we were trying to get across in the white paper, and what we hope we've turned into a paper. Now this is a big slide, but it's really I think the only time I'm going to tell you about our methods. So I wanted to put it all in one place. But this is really what we did to get to the concepts that we wanted to put forward in our work. First, we looked at a number of current healthcare trends, evidence, and policies so that we could understand the current context, which is really important when you're looking at something like the future of pharmacy topic. And from that, we came up with principles that we thought pharmacy needed to achieve. What if we start to get ourselves out of our profession, in terms of sometimes we always talk about what does the profession need to do, but what do we need to do for our society? What are those principles that we have to attain? So we came up with those, and then we looked at 10 pharmacy practice topics, and from those 10 pharmacy practice topics individually generated some future opportunity statements. And I'm going to give you a list of the topics in a minute and then some examples of those statements so you understand what I mean. What we came up with overall is we looked across all of these topics. So these were things like medication review and e-health and quality improvement and pharmacist prescribing and the technician's role, is we came up with a number of future opportunity statements. What is the research and the context for that particular topic tell us about the future opportunities for the profession, the near-term future? And from that, we generated 50 opportunity statements overall, and those actually really nicely mapped onto the principles that we thought pharmacy should strive to achieve, and those principles are listed in the yellow. We want pharmacy to be person-focused, safe, effective, comprehensive and complete, accessible, inclusive or equitable, longitudinal, collaborative, and integrated. Those are, I call that the buzzword principles, I suppose, but really, they really do mean something, you know, and these are words that we use in our professional documents and conversations, sometimes in some instances, but it is, you know, we really want to hold them as principles to hold ourselves to and how we direct our strategic, you know, our plans for the profession in the future. So from all of those opportunity statements and principles, we actually identified 2 themes that we thought were the key future directives for the pharmacy profession, and I'll tell you about those in a bit. So this is a list of the pharmacy practice topics and authors. So I won't read them all out for you, but you can see everyone's name again as authors and the variety of topics that we included. We knew we weren't going to be comprehensive to cover every single topic that was going to be important to pharmacy. For example, cannabis, which Dena's working on from the college perspective. But we thought that we had a breadth of topic and deep expertise in these topics so that for the purposes of the profession, ideas will triangulate across all of them and also will be very applicable to really the majority of pharmacy as we know it today. So that it wasn't necessary that we had to go to the ends of the earth to be comprehensive about every single thing that was going to be happening in pharmacy, but it was going to be enough to, we thought, to touch many things that we needed. We also weren't sector specific. So much of what we were doing with our lens was the idea of applying to the profession of pharmacy, no matter practice, community, hospital, primary care, long-term care, etc., and also thinking about how pharmacists interacted and pharmacy staff interacted amongst those sectors. So it wasn't intended. Most of this wasn't intended to be sector specific. We really tried to have that view as well. So we covered a number of healthcare trends, evidence, and policies. I'm actually not going to spend time describing what we thought about a lot of these things. It's in the paper. You can read the paper. I really want us to have more time for discussion, but we did touch on a number of concepts like shifting demographics, multimorbidity, and polypharmacy. So these are things I think most people here know a lot about already. The concept of the decommissioning in healthcare these days, and then when it comes to medication deprescribing. So the fact that this is becoming more of a culture. The fact that our Ontario government has certain policies and strategies, and even though we've changed the actual government, who's in government, much of the intentions of these policies are still in place. So Patients First Action Plan, mental health and addiction strategy, and other sorts of policies and strategies to take into consideration. We considered things like the patient's medical home, which is a concept that College of Family Physicians put in place so that everyone should have a medical home that is their first point of contact and their longitudinal contact with the healthcare system. A pharmacy is not someone's medical home necessarily. A pharmacy is going to be hopefully very integrated with someone's medical home, which is usually a family physician office. But that we are part of the primary healthcare system, and we want to be very, very attached to someone's medical home. The concepts of understanding, monitoring, and improving healthcare quality, safety, huge topics of conversation that are really important as healthcare is progressing and incorporating a lot of this into what we do in everyday lives. The concept of engaging patients in healthcare planning and policy, something else that's really increasing in how we think about anything that we do in healthcare today. and of course advances in technology. There's also the current context of pharmacy that we considered, the fact that now most policy really needs policy change, requires evidence that can support the value of pharmacy, and that there is a lot of evidence actually to support the value of pharmacy. So on the flip side, policymakers are asking for evidence. We actually have quite a bit of evidence in a number of areas, which is great. So how do we make sure that the evidence gets to who needs it? There are some places where we lack evidence, and we have to recognize where those are and build that towards. We have the fact that in Ontario, there's been an expansion of patient-focused clinical services within healthcare settings, and certainly a high uptake of medication review in the community settings and injection pharmacy services, even if implementation has been challenging. And then, of course, regular organizational level considerations in pharmacy, which affect how pharmacy is practiced. So we considered all of that. And again, we really thought a lot that all of that context that I've just talked about really leads us to think that these are principles that the profession of pharmacy needs to strive to achieve. And that led us to our challenge statements for the profession of pharmacy. So I'll read this out because this is our challenge to the profession, that recent healthcare trends and policies challenge pharmacists to provide safe, effective, comprehensive, complete, and person-focused care that is accessible and inclusive, equitable for all. And by adopting a longitudinal and collaborative approach, pharmacists can also ensure that the provision of care is integrated across the healthcare system and for all stakeholders. Again, lots of buzzwords in there, but lots of really important words that we think should be touchstones for how pharmacists practice every day and how our policies and processes allow pharmacy to do that, is the challenge for the near-term future. So this is just some examples of some future opportunity statements. Again, I'm not going to read all these. There's a nice appendix of all 50 of them in the paper. But the idea is that we mapped all of these statements to every principle. So this is a list of 5 that were mapped to person-focused care. So the first one, is explore approaches that emphasize pharmacists' understanding of an individual patient's experience with medication, including positive and negative effects, in order to help pharmacists work with patients to weigh risks and benefits and identify steps to increase benefit while minimizing risk. That's a huge opportunity. Is that happening in every pharmacy setting, every time, with every patient? No. I can say no, it's not. Is it happening sometimes? Sure. But we need this to be just what we do. And just as an example, that's just an example of what we do. So from all of that, we came up with 2 future directions for pharmacy. There needs to be organizational change within the pharmacy setting. So that's like enhancing pharmacy care, and also building better external relationships, so better connections. And we feel that a pharmacy profession that demonstrates achievement of internal organizational change, in other words, enhancements internally, and better external relationships, in other words, being better connected, will be well suited to meet the medication management needs of Ontarians for the purpose of improving health outcomes. It seems really simple, but I'm going to keep saying it's not so simple. If it was so simple, we wouldn't be having these conversations year after year after year. So it's not that simple, but it's really, really important as our future directions. So organizational change really involves implementing specific policies and practices to support proactive, comprehensive quality care for individual patients in every pharmacy setting and within organizations that support pharmacies. And better external relationships means that the profession of pharmacy needs to transform how it connects to patients where they live and with other healthcare organizations. And that involves building better connections of the profession of pharmacy with patients where they live, and also strengthening relationships with the patient that ensures the pharmacist understands the spectrum of the patient's care. So I think now I'm going to try something technologically advanced for me. We're going to try doing a video.
And we're good.
Great. I don't have to talk about that. So, because the video worked, I didn't have to use my backup plan, which are those other slides. Which is really good. So, the video really, in what we think is a fairly simple way, tried to get across, what would pharmacy be doing? What's that going to look like 5-10 years out? This is, again, hopefully every interaction in every sector with every pharmacist. These are the things that are happening, and this is just what our everyday life is. And so, in order to make that happen, a lot of changes do need to happen to get us there. And I recognize that in every sector and every professional, pharmacists and pharmacy staff that's looking at this will see themselves doing some of these things. But the whole is actually more than the sum of the parts. That in fact, my belief is that patient care, we're not fully realizing the potential of pharmacy or doing the best for our patients without all of those pieces working together, and that's actually been one of our biggest challenges so far. I think we have to make these changes because otherwise we really do risk becoming irrelevant, and that a lot of shifts are required, including a lot of alignment with multiple stakeholders. There are a number of evidence gaps to this, and of course the researcher in me says, okay, that's good, there's some work to do before I retire, which is nice. But we really need data on implementation of many different kinds of approaches from different perspectives. We need data on health outcomes as a regularity that we get and understand at the individual and organizational and community level. And also healthcare resource utilization changes if we actually make some changes in practice, and that this new evidence will really help us in hopefully an iterative way as we hopefully become more part of the learning healthcare system. So with that, I'm going to conclude my main remarks just to say that we hope that we've provided a picture of the near-term opportunity ahead, and of course the next challenge is, how do we get there, which is the enduring question, I think, in pharmacy. And so I'm going to turn it over to Susan James, not to answer that question, because that would be a lot, but just really to give her perspective on the background to the white paper and sort of where she sees that fitting in the future in terms of the college, who is only one stakeholder in professional change, but has sort of instigated this work, and so I thought it was great to be able to provide your perspective. So Susan's the Director of Quality at the Ontario College of Pharmacists. She's worked there since 2006, and she's really responsible for the strategic direction and alignment of registrant competence, hospital and community pharmacy practice and operations, and strategic policy planning in the analytics team. And I'm going to leave it at that, but I think we're really looking to starting our discussion, and then hopefully all of us continue. Thank you.
Thank you, Lisa. And I'm definitely not answering that question, but am really excited about the opportunity, and really welcome the opportunity to come and just speak a little bit about really the background from the college perspective that led us to the call to Lisa, the call to open with such a request to create a paper on the future of pharmacy practice. Why did the college do that? What was going on that sort of led to that, I guess, is where I want to start, and then we can get into, so what next? As I said, it really was about 2 years ago that we were having some conversation, although when you hear about the things that led to it, this has been long-term, and I wouldn't dare to put actually the number of years that the effort in terms of looking at pharmacy practice and optimizing that practice, the language of optimizing practice is very familiar, I know, to certainly many of the people I see in the room here, and I'm sure to the others that are listening. So 2 years ago, there were really a multiple number of factors, observations that we were making at the college, reflecting in terms of our place at that time. We had a change in our leadership as a new registrar coming in. So quite naturally, we were looking back a little bit, reflecting where had we been, what were we focusing on, and where were we going to go in the future, looking towards a shift in terms of evidence and how we were going to tie ourselves perhaps differently to the system than we had been putting energy to in the previous number of years. So just to give you a little bit of a sense of the key things, really, I think there's probably about 4 key things that were drivers for this work. One was in 2017, I'm talking about, we were at that time really wrapping up what was a 5-year study, and Zubin's here in the room, who was leading a partnership that the college had established with the University of Toronto that really stemmed out of the 2012 additional scope, what some people I think still call expanded scope, and we prefer to call scope. But we did at the end of sort of once we had that scope in place, and it was quite significant shift for the profession. We did engage a partnership with the University of Toronto to really take a look at how that change in practice would occur and to what extent it was really going to optimize practice. Recognizing that additional scope came right on the heels of the regulation of pharmacy technicians, which also was an initiative that the college had put in place with very much an intention that it would advance the practice of the profession for all. So as we were coming out of 5 years of studying and a number of activities that had happened, publications that had been done, and at the same time open really in place, and a number of research papers that were coming out, we started to take a look at all of that and certainly identified that while there were many good things happening, there was still lots of opportunity for growth, for further uptake, a number of areas where there was evidence of barriers for individuals, for pharmacies, for organizations to really be able to move forward in a way that was intended and what we felt was available. So that was one of the things that we took a look at. In addition, at that point in time, a couple of years ago, the college was really in a place where we were feeling quite solid in terms of looking at data that we were beginning to generate from an entirely new approach to our quality assessment model and going out into pharmacies and doing what are called practice assessments. And I suspect that most people are familiar with those at this point in time. A couple of years ago, we had about 2 to 3 years of quite solid data at that point and pretty solid numbers of pharmacists we had been out to. We were looking by then at having 3,000 pharmacists that had been assessed. And what we saw there was significant opportunity for further development growth. In terms of ideal practice, the data showed us that while only less than 3% of pharmacists that we were assessing fell what we would say below that threshold of expectation and the standard that we're looking for, and that was very consistent with many, many years of quality assurance assessments. On the other side, we had less than 10% who were performing ideally on what are 14 indicators of practice on our current standards of practice. And that meant we had over 80% of people who were somewhere in between. Unfortunately, a good number on even that lower end. And so we just recognized there was great opportunity for us to do more with what already is in place in terms of standards. The other piece I've already noted was the pharmacy technician regulation. So a couple of years ago, we were moving along over of having technicians regulated and recognizing that we were not seeing the uptake, the integration of technicians in practice, and again looking at was that contributing. We had anticipated with the regulation of technicians when you go back to its early days, and part of the rationale for that was to provide the support so pharmacists would be able to do more activities. We weren't seeing that in the way that we had intended, and so that's of concern. when we go into pharmacies, we ask the question about integration of technicians, and at that time we had reports that less than 20% of pharmacies in Ontario reported to us that they were fully utilizing pharmacy technicians. So yet another sort of driver. And I guess the last one, excuse me, was really the ongoing challenge and struggle and feedback that we have at the college about scope of practice and the desire for greater scope of practice. There had been incremental things that changed, vaccinations. So whenever there are any of those bits and pieces that come forward, there's always, couldn't it be more? And recognizing that in Ontario, certainly some recognition that compared to other provinces in the country, it was becoming very evident that we were not leading. In fact, we were falling much further behind in some areas of scope of practice. And so what about that, and shouldn't we be pushing that forward? While at the same time, we had some of our other data, and we had this new model, which Lisa has already described, MASMO, which I think is how we pronounce it as well anyway, to say that if we were going to go forward with requests for more scope, there needed to be some pretty solid evidence behind that on benefits to patients' needs, both benefit and need at a patient and a system level, essentially those four things that we needed to take a look at. And so we knew that we would have some work to do to be able to take forward any additional scope in that sense as well. So all of that really led us to scratching our heads a little bit, and what do we do? First, recognizing that we needed to get back to a focus, as I said, we'd had before, on optimizing practice, and that began the development of an optimizing practice strategy, which is still in place. And as a part of that, thinking about it and thinking, we know right now what we probably need to do, but really where are we headed? That whole concept that if we're going to begin to think about a strategy, we need to have some sort of a vision and a point that we're aiming to. And that really was the future of pharmacy white paper. The desire to have the group take a look at those gaps from MASMO, but also to really help provide some focus and to raise the awareness within the profession. We knew right at the very beginning, although we had been involved in all of these things, that the issues, the challenges, and the solutions were well beyond the scope of the college. This was not a regulatory issue. This is a profession issue. And so we needed to think about a strategy that would allow us to get the profession engaged in some of this. And that's what we are looking for in the white paper. Lisa had asked me to talk a little bit about how have we seen it, and I think we're really just feeling that this is almost the launch in a sense with the publication coming out. The paper itself is a good read, but it's a long read.
It is available on the open website, or will be for download, yes.
Yes, it is available, but I think that we're quite delighted that there is a publication. That was one of the things that we had hoped would come out of the white paper, so that it would be much more accessible, widespread awareness, and from that we really are looking to the dialogue and to the input. I think very immediately though, in terms of the council and what we've seen, certainly the work on MASMO has been very helpful. We know where the gaps are, and that will guide us as we go forward. We're very pleased that it is system focused and that it does really address societal need in that sense, which is in line with the work we're doing. And it will assist us as we continue to move forward with our strategy, which is also one of our next steps with that, is to bring stakeholders to the table together, and the paper and the future statements will be part of the background work and a platform that we can take off from and have conversations as a group in terms of where to go. So that's really the background, and I think we can open it to some questions. And the college, I as well, individually, I'm just very interested in the response, the reaction. When people read those statements, hear what Lisa has described, does it resonate? Really, one of the first questions that I would have.
Yeah, that's great. Thanks, Susan. So we'll open it up for questions, and for those people online, hopefully you can hear me. I'm a little bit behind the computer now. Please feel free to use the question pane and write in comments or questions, and we'll do our best to read them out. But really, opening it up to everybody here for feedback, comments. Bill, how did I know?
Here, one over. And there was one online.
Okay, thanks.
Anyway, excellent work. Congratulations to you and your group. Just wondering, given that, throw out the figure, 90% of community pharmacies in Ontario are part of a corporation, do you think that will make it easier to move ahead with many of these, or be more of a bit of a barrier?
I have a hard time answering that question. I think it's probably going to be a bit of both, like depending on what it is. This is a pretty, I've seen from our corporate colleagues are a lot of strides in trying to achieve some of these goals, which is good. And I think that there's also a sense, I certainly get a sense overall from anybody that that the profession feels, including the corporate partners, that we've got to do something, or we've got to keep moving along from an evolution, that more not doing anything lately seems to be not a good strategy, I guess. That does not seem to be working out so well. So the imperative to change is, while I feel like I've been talking about it since a while, won't say how long, I guess, it feels like it's change is happening externally in the profession that's causing more things more rapidly to happen. So I'm kind of, I don't know what you think, but that's.
Yeah, I think it is a very difficult question. And I guess in response, I would almost say they have to be involved. There is exactly your point. So much connected to the profession, and the change needs to happen. And so we have to find a way to work together. And certainly, I think, as Lisa said, that we are aware of and seeing good signs of that desire, awareness of the need for change, and we all really have the same end goal at the end of the day. So I think in that sense, we are positive, although we do recognize that it is seen to be a very big, significant barrier, I think, and so it is going to be a challenge to get across, and we would welcome thoughts about how do we do that? How do we manage what is seen to be a real barrier there in terms of corporation, environmental pressures?
Sorry, go ahead and then Peter.
So kind of along those lines, in terms of like corporate barriers, I guess, or environmental barriers, I'm just thinking along the lines of integrating like registered pharmacy techs, especially within community environments. I know it's kind of been mandated in hospitals now. I'm just wondering what stakeholders, I guess, have to say about that. Like,
so I'll just repeat the question. The question was a bit about pharmacy technicians and their integration in community practice, and how what stakeholders think about that. And it seems like it's more evolved in hospital practice. How's it going in the community? You're asking the exact right person, so that's good. Not me, by the way.
So there really aren't any easy questions related to this. We know, and when you look at our strategy, it is one of the areas we have identified. Again, it comes back to very much that issue of business models and recognizing that there is a business model that is associated with practice. And I guess what I can say is we're aware of that, and while we recognize there are challenges, our efforts now are really to tap into those places that are doing it. To try to understand what's going on. We're excited within the strategy, a few different things that are happening. We have somebody who is just newly signed on with some desire to take a look at the development of a business model, trying to establish what that might look like and to take that in a way that we could spread it to other places. So we're very excited actually this year to have an individual that's going to try to work on that in the background, and hopefully by the latter part of this year, we will have something to come out to say it totally didn't work, or in fact, here are some things that could be business model related that could be spread to other pharmacies. So we're trying to do those kinds of things. We have done recently further focus groups to try to understand more fully what's going on. And next, really looking at, as I said, bringing the stakeholders together. We need the corporate players sitting down with the pharmacists, the technicians, the educators, the college at the same table and talk about what needs to happen, what are the different pieces that need to fall into place. And technicians is a big part of this. When we go back to the original concepts of technicians, and I think more and more there is evidence, there is research that's being done internationally about the role that technicians can play to support the advancement of pharmacy as a profession.
I think also, maybe it's a little bit of a digression from what you've just said, Susan, but related, I hope, is that one of the aha moments that our writing team had was that we started to look at the pharmacy as a pharmacy versus just some pharmacists that had to do certain things and some technicians that had to do certain things that weren't actually working very well together. But in order to provide exceptional professional practice, the pharmacy had to be connected in certain ways to others and to people at home in certain ways. The pharmacist and the technician had to be working together well. The pharmacy itself had to have certain processes in place that let them even connect with other pharmacists in other sectors. Like the pharmacist right now, the focus has not been so much on what the pharmacy as an entity has to be able to do within the system, and that some of the way we've described this near-term future is with the pharmacy itself being, again, more than the sum of any one of its parts, but having to have certain things in place in order for that mini system to work within, the rest of the healthcare system, which we don't really focus on much, or we haven't really, to my knowledge, focused on as much to date.
And I just quickly want to reinforce that because I think that it is so important, and it is the conversation that is happening at many other tables to say that this really does have to be about working together, that one of the challenges, one of the things we need to continue to do as a profession is talk as a whole and ensure that pharmacists and pharmacy technicians are understanding each other in a way that they themselves as a team are working as a team and see that there isn't a competition here between one or the other, that it's about pharmacy as a whole.
So Annalise, is there somebody?
Yeah,
you
we
might
just
have a question.
had a
There might be
question.
something on somebody on the line. Yeah.
We had a question from Alan Malik, and he was asking if the MASMO framework was available publicly online.
No. And I know that because I looked
Secret
last night to
framework.
make sure I only was putting on my slide what was available online, and that's so that's what's available.
Okay. And then just a comment quickly from Katrina Mulheron. She said, this presentation has parallels to the Wicked Problems Summit in Halifax last May. This work seems to identify two problems that did not emerge at the summit: organizational change issues and building better relationships. And this is positive that I think this focuses the profession.
Well, that's great. Thanks for that. That's nice feedback, and yeah, that's great.
I can maybe just comment in terms of the question about MASMO, and Lisa, you had mentioned earlier whether I could speak to what's happening with that. I think, as you said, we have had a shifting government since that particular framework was produced. It has not been widely communicated, so I don't know for sure that it is going to move forward in the way that it was originally intended. However, having said that, I think that when you look at the framework, it makes good sense. And it is certainly worth our while having the work done, understanding where we do have gaps in research in terms of the evidence for advancing scope, and where we have the evidence already in place to take forward any scope requests.
Peter, you had a question?
Yeah, no, you ended the talk by talking about the learning health system, and there's a lot of discussion about learning health system and the possibility of using data and even machine learning and professional learning and bodies to aggregate data to learn from. But I think the unit is not just the pharmacy. It's the person in the pharmacy. It's the patient in the pharmacy. And so regardless of whether MASMO in its current incarnation goes forward, we know that there are certain individuals that cost the health system far more money than they ought to, because there's breakdown. And because the people involved haven't learned, or they don't have the literacy, or and it's not just vulnerable populations. The learning doesn't happen. And continue. So given all that, you talked of there's the discussion of the medical home was always about who's going to be the father, who's going to be the responsible adult who looks after, makes medical decisions, as opposed to the idea of a home where it's your place. You can decorate it the way you want. You can create your mind castle of what it really looks like from your perspective. And that sort of agency, I don't think has really been discussed appropriately yet. And it's certainly an area that the pharmacy, in that creating a pharmacy, a room in the mind castle of the patient, so that they can go to that pharmacy room and they can see their pharmacist and they can remember what they said. And not only that, they can report back to other professionals that this is what the pharmacist said. And that enabling that sort of remembering and learning on the patient perspective could be a very important role for pharmacists.
Yeah, absolutely. I'm not sure if people online could hear everything Peter said, but I'm not able to repeat it because it was so well said. But the concepts of us talking about the learning health system, which I ended off a little bit, in the future vision that we presented, the idea that we know people's goals, health risks, and needs are we need to know, pharmacists need to regularly check in about that. We need to know that in order to make any decisions. And if we know that and we document that, because that's another part of what is in the vision, we have that information, and that information can be used ideally to provide care that is meaningful and needed for that patient in a lot of ways. And that information can also be used in aggregate, hopefully, whether it's at the pharmacy level, at the community level, at the provincial level, whatever it needs to be, to identify care gaps, in different ways, because we'll know the health goals, risks, and needs of the patient that we've actually spent time cataloging.
And even better, with a machine learning algorithm, you can show that the only common factor was this person costing the health system less and that person costing the health system more was several interactions with the pharmacist. So the evidence
it'll allow us, that's right, it allows us to then have outcomes by which to then map out our interventions. Absolutely. So I think that's really important. I think you also mentioned the medical home and the idea that, I might humbly disagree with you that the conversations I've been involved with around medical home are not so, maybe not as paternalistic as you've described, but that if it's patient-centered, there has to be, I do believe that there needs to be
ownership. There has to be.
The patient has ownership, but there is an individual in a primary care provider that is charged by their professional duty to have a holistic scope for the patient. They don't have deep expertise in many things, and they need the pharmacist and others to help with that, not just to help, to collaborate with that. In a way that everyone's connected and working for that patient based on that person's health needs and goals and risks, but that we can be attached to the house, we can be the garage, we can be attached, however it's going to be. We just can't have the role. I think we should, and I think by thinking we might have it actually can be detracting, because we have a deep expertise in something in pharmacy, and we need to execute that.
So my point, and I'll stop after this, is there's the actual physical home, the physical pharmacy, but now there's the virtual home. And the
Yes.
virtual home has rooms and it has,
Absolutely.
and it's controlled, it's decorated, and it's created by the
Each
patient.
person, yes.
And there's a pharmacy presence in that home.
Absolutely. Each person has their own healthcare team, and I think some of the time we've been thinking about teams as the same team. In fact, is for many patients, but in fact, every patient has their own healthcare team, many of which is not even in the formal healthcare system. So how we reconfigure the healthcare system to meet that person's to work with that team is a challenge. Anyways, I'll stop because I'm on my soapbox. Suzanne.
I haven't heard much about government and private plans, so I'm wondering what your thoughts are in terms of the role for government and maybe private health plans, drug plans, in encouraging these changes and supporting, maybe even incentivizing them.
You mean payers?
Yeah.
There's government, private. Who wants to answer that question? Alan's on the line. He'd love to answer that. I mean, I think I'll just say in any of my conversations with private payers and the health and government, the strategies that they have in place are very focused on people achieving the best health outcomes using the resources in the most effective and efficient manner. So the incentives that are put in place by those organizations seem to me to ideally and have been as much as possible aligned with meeting the goals that we're trying to put forward, that we've tried to present. That's from a strategy point of view. I've never heard anything counter to that actually, or not recently. So I think that's what is your opinion?
Maybe we need to work more closely with them in moving forward, because it seems that when they've come out with policies, it's all of a sudden, but if you're working more closely with them, then pharmacies can be ready and to hit the ground running. And also they'll develop these new services a little bit more smartly, because it'll be developed, maybe do some pilot testing even as well before they launch something big and spending lots of dollars on it when it might not be rolled out quite
In the way it was intended. The
Yeah.
strategy doesn't always execute well.
Yeah.
And I would fully agree. I think to the perspective that they need to be involved, engaged, we need to engage with all of the payers in that sense and include them in this conversation.
Go ahead, George.
So now that this paper has been published, what are like the next steps that the college would like
The
to
college,
take?
We really will continue to support any activities. I mean, I think that it was really important for us to have this out there. But also it's very important, and part of why I'm really glad I'm here, to say that this is not ours, and we don't see that we own this as much as there was funding support for the development of this. I think I really do want to say that it is not our intention to direct what we do with it. It is our gift to the profession to do something with. Will we look to it in terms of information that it provides us and that we can bring to a table where we do want to bring all of the stakeholders together? Absolutely. But our desire really is to have some conversation. When you think about that definition of a white paper, what the intention really was, it's to have the dialogue. So we'll continue to support the efforts, and we hope that Open and anybody that's here will take this forward and think about places that this conversation can happen. We need to hear from the profession. As I said, what resonates, and what are the things that people think do need to happen at the various stakeholder levels to move forward.
So, sorry. So just also to say, internally, you're certainly thinking about it from the perspective of the college's strategic planning. While it's not all the college, some pieces of it will help in your thinking. And the hope is that any organization would do the same, so that for the pieces where it applies, how do people move whatever they need to move in the directions that help relate to this. This is an opportunity just to check in on that. and there's other strategies too. But in the interest of time, I will see. Go ahead, because you had your.
I just had a comment based on Suzanne's question, which is that in my experience, what payers are often willing to engage in a conversation, but inevitably the conversation ends with the payer saying, show me. Show me the evidence, show me the money, show me how does this make sense for patients and for other stakeholders. And often we're stuck because we don't have the evidence that they're looking for.
But I think that is an issue. We have to build ourselves in the profession in a way that allows us to better answer that question. Sorry, I'm going to go to Annalise, and I know we're running out of time only because you've had a chance to. So Annalise, is somebody on the?
Yeah, this one is from Clarence Chant, and he says it seems to be heavily focused on community practice. What about other facets of pharmacy practice?
Thanks, Clarence. We were trying very hard to remove sectors from this. So if you read the statements, this applies. I would debate with you that this applies everywhere. So when I think that there are things happening in hospital better than community and aggregate in some of these, they're related to some of these future opportunities, and things that are not happening in hospital or happening in community or other sectors better than in hospital. And so I think there's something in here for everybody. And when we read through it, we tried very hard to ensure that every sector most sectors, I'll say, were represented with evidence and context, and also with opportunities for the future. But I welcome a conversation about that at some point. Okay, sorry, Bill. Direct, go ahead, and then I think you're our last question, and then Bill, if there's little time maybe, but go ahead, Direct.
Sorry, it's actually more of a comment as well, having experienced the whole spectrum, well, pretty much the whole spectrum of pharmacy practice, community, inpatient, and now primary care. I really think the two things are what we really do need to focus on. Actually, three. First is the remuneration. I mean, that's the dog wagging the tail, wagging the dog, right? And second is IT integration for information to be accessible to all of us, because without that, I mean, we just get chopped off at the legs, at the knees. And I think thirdly, it's really about in producing evidence, how is it that we can work intra-professionally to try to produce evidence so that it's not negotiable, that this is an essential service. So that government wouldn't be paying just for drugs on an ODD formulary, that it would be services, just like a physician or a dentist would get services paid. Yeah.
Yeah, thank you. Thank you very much. So, sorry, Bill, do you want 1 minute for the last word?
Sure. To move ahead with this, which obviously the profession needs to, do you think the 4 years of undergraduate education we give the student is enough?
Okay, Naomi and Stella and Zubin have been doing this more than I would. What do you guys think?
Well, even without this, I don't think it's enough for our students. But going ahead with this, do you think the 4 years is enough?
Well, I think this is like directly from an area of research I'm interested in, so that's my full disclosure as far as bias goes. But I think we can't prepare students to for everything that's out there, but you can give them the skills so that they're able to adapt and learn once they are out in practice. And can that be done in 4 years? I think it's less about time, but about focusing on what we want to teach. And so you can teach people facts, or you can teach them to learn and adapt and be able to understand what they need in a new situation so they can be an effective professional. But that's just one very a small opinion, but that's kind of
you can have a disclaimer. Not my,
but I don't know. Don't really think about that. But
I mean, I think if you look at all of the competencies that the students are supposed to come out with, certainly patient care provider is an important one, but then collaborator, communicator, all of those ones. You can have the best knowledge ever, but if you can't work with your colleagues and your patients, and then we haven't achieved what we need to achieve. And I think that the challenge with that is how we provide experiences for students and feedback for students on growing those skills in an effective manner. That's a huge challenge, I think.
Okay.
I'm gonna have to stop. Sorry. So it is after 5. I know I can feel like this room would talk for a long time, which is great. And I'm really glad we had the amount of time that we did for discussion, actually, instead of sort of filling it all up with remarks. So thanks everyone for participating. Again, if you're not on the CPE mailing list, you'd like to be, let us know. And thanks to everyone online for also participating. It was great to have online participation. And thank you, Susan, for coming down to the faculty and sharing your perspective.